So good afternoon and welcome. This is a video where we're going to talk to you about one of the national clinical audits that are commissioned through HQIP, the Healthcare Quality Improvement Partnership. And it's one of a series of videos which are taking part in the National Clinical Audit Awareness Week, which HQIP is running for 2025 in the week beginning the 2nd of June. We're here to talk to you about using clinical audit to improve the care of patients with sepsis. My name's Celia Ingham Clark. I was originally a surgeon, then I became a medical manager, a medical director, and recently I have taken over as chairman of HQIP. Ollie, would you like to introduce yourself?
Sure, thank you. My name's Ollie Burton. I'm an incoming neurosurgery ST1. That means I'm about to start my surgical training in summer of this year, 2025. I'm currently spending a year away from the NHS working with HQIP to learn more about the importance of national audit and quality improvement and initiatives like Clinical Audit Awareness Week.
Now, I'm passionate about quality improvement, and I see the national clinical audits as being one of the strongest tools that we have in order to drive quality improvement in a wide range of specialties and to have a positive impact on many patients' lives. The National Emergency Laparotomy Audit has been running since 2010, and it focuses on patients having emergency abdominal surgery. And the reason that this is so important is that many patients who come into hospital with something terrible wrong inside their abdomen are old, they're frail, and they have a very high risk of dying whether they do or do not have surgery. And one of the things that makes a big difference as to whether they live or whether they die is whether they get quick diagnosis and speedy treatment by experienced surgeons. So the National Emergency Laparotomy Audit was set up specifically to look at this group of patients. If we think that the patient has sepsis, they need to get antibiotics really quickly. And if we think that the patient has infection inside their tummy, they need to get to theatre very quickly. And there are very, very clear standards for this which are involved in this audit. So just to remind you what clinical audit is about, it's about setting standards, it's about measuring the performance of a system against those standards, and then seeing what you can do to drive up the quality and then ideally raise the standards to a higher level for the future. That's an audit cycle, and that's how we do quality improvement. So when the National Emergency Laparotomy Audit was set up, as I say, it focused on patients having emergency abdominal surgery. It checked whether or not those patients were getting a preoperative risk assessment. It checked how quickly they got antibiotics. It checked whether consultant surgeons and consultant anaesthetists were involved in their care. It measured how quickly the patient got to theatre, whether or not they went to critical care after they had their operation, and it also measured the in-hospital mortality. At this point, I just want to hand over to Ollie to tell us a little bit more about the care of those patients. Ollie, over to you.
Thank you very much. Certainly, so this is something that on the ground, for example, as a surgical doctor at the start of my career, I would have been involved in looking after these patients. One of the important things that I want to raise about measuring the performance of how well we care for patients in this way is that it identifies essentially what's happening to your real life patients, because although, as Celia says, everyone, if they have a diagnosis of sepsis or it's suspected, the important things are the same. They need antibiotics quickly, they need a consultant to be involved. If they need to go to theatre, they need to be taken there quickly. All of these things are in theory the same. But if you are able to measure the performance of your service with regard to different groups of patients, it allows you to identify where the gaps are, and if there are particular groups of patients from different backgrounds or ages or sexes and genders that you might not be addressing with equal equity, leading to different outcomes. And I think that's a really stark example in the context of NELA. It helped to identify, for example, that actually more than half of all patients undergoing emergency general surgery were aged over 65, a fifth of them aged over the age of 80, and it found that the worst outcomes were seen in those older groups. So it's only by stratifying with these huge data sets, asking specifically how old are our patients, where do they come from, where are they in the country, that you're able to answer these really important questions and try and chase those better outcomes.
Thank you, Ollie. Can we move on to the next slide, please? I want to talk now about the latest NELA report. It covers patients who were treated in the years 2021 to 2023, and this is the 9th year that this audit has gone on. And what we found was that there were 27,800 odd patients who had an emergency laparotomy in this period. Nearly 85% of them had a preoperative risk assessment, but the time for them to get the antibiotics if they had sepsis was an average of 3 hours, and only 20% got their antibiotics within the hour that they should have done. And of course, that's not just a doctor prescribing the antibiotics, but it's someone actually giving them to the patient as well that is important. Involvement of consultants worked pretty well. So consultant surgeons and consultant anaesthetists were directly involved in the care of these patients in 86% and 71% of the patients, as you can see. But the time to surgery wasn't brilliant. It was an average of 15 hours from arrival in hospital till when they got to theatre. And there's very clear guidance from NICE and from the Academy of Medical Royal Colleges that to get to source control for sepsis, you're supposed to get them managed within 3 to 6 hours maximum. So there were very, very long delays. They also found that most of the time was spent waiting for something to happen. That long delay wasn't because they were having more diagnostic tests or having to see another specialist or anything like that. It was just waiting for the next thing to happen. So there's clearly an opportunity for improvement here. 80% of those who are considered to be high-risk patients went to critical care after theatre, and the in-hospital mortality was 9.3%. Now, when NELA started, they started in 2010, and then the mortality was 15%. So there has been a significant improvement, but that improvement happened some time ago. And what has happened recently is that the results have plateaued. Next slide, please. So as a consequence of this, and because the results have plateaued, NELA has made several recommendations. First of all, they've asked that the Royal Colleges of Emergency Medicine, surgeons, anaesthetists and physicians should publish consensus timed pathways for patients needing emergency abdominal surgery. And indeed, the Royal College of Emergency Medicine has already put something out on its website, pointing out the importance of this and the importance of getting the patient seen and treated quickly. The second recommendation is about managing older, frailer patients, as Ollie has mentioned before. And it says that the joint Royal Colleges should develop common competency-based training curricula so that these patients are managed well. And the involvement of a care of the elderly doctor is really important. The third recommendation is to make sure that care of the elderly services are involved in these frail elderly patients having emergency surgery. And fourthly, a recommendation regarding people who come from deprived backgrounds, because unfortunately and unsurprisingly, people who come from deprived backgrounds are more likely to have poor outcomes after they've had a laparotomy. So those are the things that we wanted to talk to you about. Can we move on to the next slide, please? We've now got an opportunity for questions, and I know, Ollie, you've got some questions already, so shall we move on to that?
One of the obvious ones, Celia, that I think came up in a previous discussion that we'd had is, I wonder if there is a gap in understanding of the importance of timely performance as described in things like NELA between senior surgical staff such as yourself and junior surgical staff. My first question, therefore, is, when there is a large-scale audit project, something like NELA or EPOC or any of these large-scale studies and trials that affect patients, as a consultant running a surgical service and looking after patients, how would you yourself develop or maintain awareness of these large and important projects? How do they get to you?
That's a really good question. As a consultant, if you're a fellow or a member of a Royal College, you will be sent relevant audits through your college. It's one of the things colleges do as part of providing continuing professional development. But ideally, there should also be a governance system in the hospital trust where you work that ensures that where something comes through to the medical director, because all of these things arrive with the medical director, the chief executive, and the director of nursing in a hospital, they should make sure that they go through to the relevant department, not just as here's something, off you go, but here's something. What's our performance like against the standards in this, and what are you doing in your department in order to try to improve and achieve these standards and improve the care of your patients?
So there are potentially multiple ways that a given consultant might become aware that something like Neela was running, for example.
Yes, but I mean, a fair number of surgical and anaesthetic consultants will have a direct interest and involvement as well, and so will be on a working group involved with developing the audit going forward. So, for example, they've done a piece of work this year looking at patients who were managed without going to theatre, perhaps because they were thought to be too sick for that, to see what the outcomes have been in those patients.
Fine. And then the second part of what I was wondering there was how this trickles its way down or doesn't to junior surgical staff, because my first ever job as a doctor was working in general surgery in a very busy unit with lots of sick and comorbid patients, and national audit was probably the very last thing on my mind, under those conditions. And I guess my question is, how do we bridge that gap?
I think in general terms, the national clinical audits are not well enough recognised by staff on the ground. And that's not just resident doctors, but also nurses and other healthcare professionals directly involved in the care of patients, because these need to be seen as tools to help you improve the care of your patient, not as an additional burden. So if I were a surgical resident again and I had a patient who I thought had peritonitis, that is infection inside their tummy, and I knew that they're supposed to get to theatre very quickly, I would be able to use the information from the audit to negotiate a rapid slot in the emergency theatre. I'd need to speak to the theatre manager, and I'd need to speak to the anaesthetist and potentially to other surgical teams who also had patients waiting to go to theatre. But I'd need to use that audit information to help me. So people should see it as a tool that helps them, not as a burden.
Yeah. And then the second sort of major thing that I wanted to ask you about, especially in your surgical career, this is coming from the perspective as someone, touch wood, about to start a surgical career, is I must get the name right, but Neela itself had a precursor project called the Emergency Laparotomy Network, which I gather was set up around the same principles. Over the course of your career, how has the landscape of national audit and service evaluation changed, do you think?
There's been a massive change. When I was what was then called a junior doctor, there really weren't any national clinical audits out there. And I don't think it's just that I was ignorant as a junior doctor. I don't think they existed. I think the longest standing surgical one is the National Joint Replacement Audit, which National Joint Registry, which has been going for a long, long time. And I remember when that first came in, and I was in a medical management position in the trust where I used to work, and I engaged with the orthopaedic consultants to ask about their performance against this audit and what they were going to do to try to improve. And it was quite revolutionary. The challenge, of course, is that usually it's a situation where there's no extra money available. You're being asked to improve the quality of care for patients through this without having extra money. And therefore, you have to look to see what it is that you can do. Part of it is about engaging with people so they understand why it's important. Part of it may be about deprioritizing something else, although there's relatively few things you can deprioritize in the NHS. But also it's about engaging with the other groups of staff as well to understand the importance of this. So if I just talk about the sepsis side of it, we know that for many things that people come into hospital with, how quickly you treat them doesn't make a lot of difference between doing it within 4 hours and doing it within 24 hours. And indeed, a lot of people who come in and need emergency surgery can safely wait until the next day daytime to have their operation. That isn't the case for people who've got infection inside their abdomen. If you've got sepsis, you need treatment quickly, and every hour of delay increases the risk of dying.
That you've preempted with what you've just said my next question, which was often, obviously, depending on the findings of national audit programs, I can see how it might be tempting for if I was working as a surgeon and the team came back to me and said, this national audit has shown that we're performing well below standard, it would be tempting to turn around and say, well, there's no more money. What do you want me to do? And that, I imagine, can lead to some very difficult challenges, as you say, in terms of deprioritizing or thinking where that money is going to come from. And did you have any experience? It sounds like you've been in management, in how that process, which sounds very difficult, is navigated.
Yeah, I think it's part of the qualities that we expect of people who are leaders in the NHS. We need people who will go and talk to others to explain their position, and also, really importantly, listen to others as well, to hear what the other people's perspective is and why they say that you can't do something differently. So if it's saying you're trying to get a CT scan of the abdomen for this sick patient, and the radiology department says, well, there's huge queue, there's not a chance you're going to get it till tomorrow. Yeah. The solution is not actually to go and stamp your foot. The solution is to go and talk to people when things are quiet. You go and actually explain why, and see if you can develop a standard operating procedure for your trust and get it negotiated and agreed with the other department, so that people recognize that if you use the sort of almost like the safety word, peritonitis, then that gets you to the top of the queue. And there will be similar things in other specialties. I know that a supracondylar fracture in a child is something that has to go to theatre very quickly. In your own specialty, Ollie, in neurosurgery, if somebody's actually got an extradural hematoma that needs to be evacuated, or a subdural, that needs to go to theatre very quickly as well. So I think having standard operating procedures helps, but a lot of it is about your relationships with your colleagues and talking and listening in order to find a consensus way forward.
Thank you. Once again, preempted my next question on the list. We're going chronologically, which is one of the major findings, as you say, of NELA, or one of the things that jumps out from reading the report, is the enormous radiological demand, because your CT scan, for people unfamiliar, is going to be part of the diagnostic protocol for working out whether someone's got a potentially infected collection or something inside their abdomen. And that highlights, obviously, the multidisciplinary nature of what we're working with here, because although NELA is in theory a surgical audit at its heart, actually, based on what we've just been talking about, you've got surgeons, radiologists, anaesthetists, geriatricians, and I was wondering, again, based on your own experience as a consultant and thinking about how you're trying to work on these outcomes, how have you worked with other consultant colleagues to try and improve services?
Yeah, well, almost everybody is actually in the NHS to try and make things better for patients. But quite a lot of us also find some of the systems quite frustrating, because there will be resource constraints. I have to say, though, that access to emergency CT scanning has improved massively over the years. Most hospitals now run at least one emergency CT scanner 24/7, with the appropriate staff to support it and the radiologist to interpret the reports and so on and so forth. So the situation has improved enormously, but there will still always be resource constraints. And again, it's about talking with your colleagues, getting an agreement as to what the evidence shows about what is important. Because if you keep going to people and saying, my patient's the priority, and you haven't got the evidence to back that up, people will stop listening to you. So you've got to only use that argument when you've got strong evidence that this is the type of condition that needs to go to the top of the queue, and you get those standardized operating procedures that I talked about into place, and that makes a big difference.
Do you think, well, this is very hypothetical, and I hope it doesn't happen, but similar to what I was saying before, that I can imagine that working amidst the context of national audit programs runs the risk of showing that any given department is underperforming. I suppose by the law of averages, that's going to happen. And in some senses, the easiest solution would be for any given surgeon to say, well, I don't want to participate in this national audit because if I find out that I'm performing worse, then I have to do something. And I don't want to do that. I just want to go to work and operate. Do you think there is a duty as such, a requirement to participate?
Yes, I do. If you read Good Medical Practice from the GMC, it's very clear that you, as a doctor, are expected to participate in quality improvement activities for the benefit of your patients. So when I was a trust medical director, I would have been extremely unhappy with any surgeon that tried not to take part in the relevant national clinical audits. And again, it's about whether you see it as something that is a tool to help you or whether you see it as something that is a stick to beat you with. And it's a tool to help you. And it helps you make your case for the resources. So if you're trying to say there isn't enough CT scanning, if you can go along and say, look, this evidence shows that you've got to have a CT scan within this period of time in order to reduce the mortality for this group of patients, that's a very strong argument if you're making a business case for another CT scanner.
And when do you think in your career you started to develop that awareness? I mean, I've done this slightly out of joint in that I asked about the difference between senior and junior doctors earlier on, but there is a real gap, I think, at the start of your career, certainly, where these large scale problems almost don't seem like your concern, even though I suppose by definition they are. But as a surgeon, when did you start to appreciate the importance of these studies?
I think, well, we all want to make things better for our patients. And initially, a lot of that is about self-awareness and self-control so that you make sure that you know the right way to do A, B, C, D, E in an emergency, or how to assess a patient and then present them to a consultant and so on. But once you've got those basics under your belt, you're then looking for other ways in which you can improve the quality of care. And sometimes it's about what you do. Say you're an FY1 doctor on the ward, it may be about how you communicate with the ward nurses and the ward sister so that they help you and you help them, rather than finding a situation where there's tension between the two. And that will improve the quality of care for your patients. And then I found I started to think, well, if I could improve care for this group of patients, how can I make it more widely applied for others as well? So for example, I introduced emergency day case surgery for people who presented with perianal abscesses. And I tried it myself with patients with informed consent, and it worked. I ran a randomized control trial, which worked. And I had to then persuade my colleagues, not just in my trust, but in other trusts, that there was evidence that this worked just as well and saved money for the NHS. But it involved quite a lot of communicating over a period of time to get there. So it's another reason why we all need to be good communicators, and we need to listen to one another, because the speed of change of technology and what's available to do for our patients is frighteningly fast. It's all so different from when I was a resident doctor myself that we can't individually cover absolutely everything. And therefore, teamwork is a really important aspect of developing your leadership in order to drive the quality of care up.
And how did you know what to do, in a sense? You know, I think I came out of medical school probably like most people do now, which is you have a sort of low level understanding of what audit actually is. You've probably not done any at that point, let alone led a randomized controlled trial on anything. You know, how did you figure all this stuff out?
I think in terms of audit, I can remember exactly when it happened, because I was working as a research fellow in a surgical department in London, and the professor was allocating tasks in terms of who was going to present on what at the grand round. And he said, Celia, you're going to do a presentation on clinical audit. Off you go. So 1991 that was. And I went away and read up what clinical audit was and what the audit cycle was. And it just made a lot of sense to me. And so I've been a strong supporter of the clinical audit process ever since.
Oh, I think it's it's incredible to hear what motivated individuals, and I think we're still at the stage, for better or worse, where these big changes only do come from motivated individuals who are sort of fighting against the odds to make these changes happen. And certainly my experience with audit, as I think is going to be the experience with many resident doctors, is particularly early in your career where you're rotating between departments every 4 months, every 6 months, whatever. Often sustainable change is one of the hardest things to try and embed into a department, and it's certainly been my experience. As soon as you do your great project and it looks great and everyone's happy about it, and then you leave and you come back in 6 months and everyone's forgotten about it.
Okay, so part of my role is to motivate resident doctors. I feel that's a really, really important thing that I can do. And getting involved in audit and quality improvement in a way that makes a difference for patients is one of the most exciting things that you can do. It's exciting and interesting, and it continues to be exciting and interesting, even when you've been doing it for years and years and years, because it is a lever you can pull to make change. Now, your point about rotating between departments certainly is important. And that's why, if you're setting up a clinical audit, don't do it all on your own. Get other people involved. Get people who are permanent members of staff involved, whether it's a pharmacist or a physio or a nurse, and get a consultant to sort of sponsor you and sponsor the program, so that if you make something work, then they potentially, with the person who comes on the rotation after you, can take it forward. And then similarly, when you go to a new department, ideally there will be a project that someone has started that you can then follow through on. Now, I know that the Royal College of Anaesthetists does a pretty good job on this to enable anaesthetists in training in order to let them get involved with clinical audits. And I think there's an opportunity for more specialties to do that, because we want people who are resident doctors to get engaged with these national clinical audits, not just in an individual, very focused audit on a very small topic that doesn't have the power that these national clinical audits have to improve things.
Yeah, and I think that has certainly been at the start of my own research career as well. I was employed as a research fellow last year in a surgical specialty in London, and that word power is so critical, I think, to this discussion, and for any of my resident doctor colleagues or medical students who might be listening to this recording when it's live. I think the simplest way of viewing it, the larger your data set is, and the more closely or well-defined your research question or your inquiry question is, the stronger your signal is about answering your question. And a lot of the problems with the types of audits that I've done and we are encouraged to do is you're only working with a single department's worth of patients over a very small time window. But when you're thinking about these national data sets, which are gathered over months and years, and years, some of them have been going on for decades, the value of that data, you almost can't get any other way, right? It's one of the most powerful tools we have.
Yeah, and the national clinical audits are a real jewel in the NHS's crown. There aren't other countries that do them to the degree and the extent that we do in this country, and they've been a powerful tool for improvement.
Yeah, so I think as a junior doctor, and well, I mean as an early careers doctor, but as a researcher and someone who might be thinking about research and quality improvement, I think I was so unaware for a long time of how rare things like the national audit programs are, and probably how underutilized they are as a data repository for high quality research, because the data is already there and it's high quality, way beyond anything that you could ever do by yourself with a small team of researchers. My final question, Celia, that I've got prepared at least, is throughout your career, you've told me already that things change dramatically, and there's been a relative expansion in national audit and data monitoring. We're now, it feels, on the cusp of a real paradigm shift when it comes to artificial intelligence and machine learning methods and things for interrogating these enormous data sets, which we've never been able to do. Where do you think the future is going? Where, if we were the other way around, I'm now at the end of my career, what do you think things might look like?
That's a really big question. I think AI will have an opportunity to make a difference, but we've got to make sure that the data is right in the first place. So as we move on to electronic patient records, I think there does need to be built-in checks and balances to make sure that the right box is ticked and we've got accurate information in there. And I'm certainly thinking about the use of AI, for example, in radiology. And I understand that the learning can be skewed. So when they showed the AI chest x-rays and asked it to diagnose pneumonia, the AI system learnt that if it was a portable chest x-ray, it was more likely that pneumonia was there. And so it started using that as one of the criteria to diagnose pneumonia. Mm-hmm. So you've got to have some human control involved, but AI can save a lot of time. And as far as the national clinical audits are concerned, one of the things I'd like to see as soon as possible is that data can be brought straight from the electronic patient records into the national clinical audits, rather than individuals having to take things off one screen and type it into another computer in order to submit the data. And I suspect there's a lot of people out there watching this now who are nodding furiously at that.
So a more streamlined, I broke my wrist last year, for example. So if I went into hospital and I was seen in A&E and maybe had an X-ray of my wrist, etc., or an MRI or whatever, that any data that was relevant to an ongoing national audit program from my stay would be just seamlessly pulled.
Yeah. And I think most people expect that NHS IT is joined up nowadays. Yes, there are some people who are concerned about data sharing and so on, but the majority of people assume that if you're seen in one hospital and then seen in a different hospital, the information is immediately available. And I believe it should be.
Okay, so my final question, Celia, that comes to me now is one of the most important things I think I've learned during my year with HQIP is the patient involvement that the organisation has, and its fantastic PPI board, and it's something that doctors know is critical in research as well. So we're very used to the idea of PPIE, as we might call it. When we're talking about national audit, what do you think the role for the patient voice around audits, decision making, managing care might be?
All the national clinical audits have got patient and public voice involvement to help them produce the appropriate type of standard that patients and any of us would want to see for any of our relatives if they were in that situation. So with the NELA National Emergency Laparotomy Audit, the reason this is really important is that what the patients go through, first of all, it's a really, really bad thing they've got wrong with them. Secondly, in most cases, it can only be fixed with an operation. And because it's an emergency big operation, they've had very little chance beforehand to gain information about what's involved, what are the risks, what are the benefits, what are the reasons why they should say yes or should say no to the operation. And so if I go back to being a surgeon, whether as a resident doctor or as a consultant, then when I go and talk to the patient and their relatives, I'm in a position where I can say, we've got very good data that shows that the risks are this and the risks are that, and we will do our best to help you, but we would strongly advise that you go down this route and that we want to get it done as quickly as we can because that will give you the best possible outcome. So it means I can give them pretty objective information about what the risks are for them personally and help them to make a good choice. And the good choice is not always an operation, but for many it is. So thank you for those questions, Ollie. I hope that's been helpful. We've had an opportunity to talk to people about NELA, the National Emergency Laparotomy Audit, one of the national clinical audits, and what it means for patients and what it means for staff in terms of trying to look after those patients who've got such a serious thing wrong with them. This has been a session that's been run as part of the Clinical Audit Awareness Week 2025, and I hope that those of you watching this are also able to take part in other parts of this programme during the week. Thank you very much.